Hi and welcome back to another video of Medic Notes. This video is on cholelithiasis. Cholelithiasis refers to the presence of gallstones in the gallbladder, more common in females than males. There are two main types of gallstones: cholesterol and pigment. Cholesterol stones are the majority, 85%, radiolucent, found in gallbladder. Composed of cholesterol, yellow, finely granular, hard and faceted. Associated with 4F, fat, female, 40, and fertile. Formation is due to disruption in the solubility equilibrium of bile, such as increased cholesterol secretion in bile, old, obesity, rapid weight loss, hyperlipidemia, and increased estrogen levels. Can also be due to decreased emptying of the gallbladder, due to gallbladder malignancy, gallbladder hypomotility, pregnancy, or fasting. Pigment stones is minority, 15%. It can be black and sterile, which is radiopaque, form in gallbladder. Composed of calcium salts, hard, speculated, and brittle. Formation is due to increased secretion of bilirubin conjugates into bile. Gallbladder hypomotility, decreased bilirubin solubilizes, and bile stasis. Another type is brown and infected stone. Radiopaque, formed in intra and extrahepatic ducts. Composed of calcium salts and bacterial cell bodies. Check for ampullary stenosis, duodenal diverticula, abnormal sphincter of Oddi. Related to recurrent pyogenic cholangitis. Formation is due to infection or biliary stasis. Other two pigment stones are mixed and biliary sludge, which is defined as microlithiasis suspended in bile, predisposes to stone formation. Can be visualized on the ultrasound scan as layering in the biliary tree. Sludge is a pre-stone condition, but not all sludge becomes stones. For its clinical features, patients can be divided into three clinical stages: asymptomatic, symptomatic cholelithiasis, and complicated cholelithiasis. For asymptomatic, the stones are detected on routine imaging studies or incidentally at laparotomy. 10 to 25% of patients will become symptomatic after 10 to 15 years of follow-up, usually present first with biliary colic. Once patients have biliary pain, the risk of developing complications is 2 to 3% per year. Cumulative incidence of developing severe complications lower in asymptomatic patients compared to those with mild symptoms. Next, for symptomatic cases, patients present with biliary colic, gallbladder contracting in response to hormonal or neural stimulation, forcing a stone against the gallbladder outlet or cystic duct opening, leading to increased intra-gallbladder pressure. Site of pain are at epigastric or right hypochondrium. Onset is usually occur within hours of eating a meal, often awakening patient from sleep. Character, not a true colic, more like waxing and waning character, but rarely have pain-free intervals. Radiation, to inferior angle of scapula or tip of right shoulder. Alleviating factor, not relieved by squatting, bowel movement, or flatus. Timing, distinct attacks lasting 30 minutes to several hours, often resolve spontaneously by 6 hours. Exacerbating factor, not worse with movement. Severity, steady and intense pain. Associated symptoms, nausea and vomiting. Patient usually gets better after vomiting. Other symptoms are bloating, abdominal distension, epigastric or retrosternal burning sensation, back pain, left upper quadrant pain. Biliary colic is a herald symptom that indicates risk of further sequelae. For complicated cases, in the gallbladder, hydrops of the gallbladder, which is impacted stone without cholecystitis. Acute calculous cholecystitis, leading to acute gangrenous cholecystitis or empyema of the gallbladder. Porcelain gallbladder or chronic cholecystitis, leading to increased risk of GB cancer. Marizzi's syndrome, leading to obstructive jaundice in the common bile duct. Cholelithiasis, leading to obstructive jaundice, ascending cholangitis, secondary biliary cirrhosis, gallstone pancreatitis. In the gut, cholecystoenteric fistula formation, leading to intestinal obstruction or gallstone ileus. Bouveret syndrome, leading to gastric outlet obstruction. And gallstone dyspepsia. For investigations, first, plain abdominal X-ray. Pickup rate for gallstones is less than 10% since most stones are radiolucent. Second, ultrasound of the hepatobiliary system, which is the investigation of choice for gallstones. Even more sensitive than CT scan for stones since CT may miss small stones due to the spacing of the cuts taken. Features of stone on ultrasound are strong echogenic rim around the stone, with posterior acoustic shadowing. Third, CT scan, usually not done to diagnose stones. Usually done in symptomatic patient where it is uncertain what is the cause of symptoms, looking for other differential diagnosis. Can also be used to detect complications of gallstones. Fourth, MRCP, Comparable to ERCP, and also minimally invasive, preferred to ERCP if patient does not require any therapeutic intervention that ERCP provides. Fifth, ERCP. For therapeutic purposes like stone removal, sphincterotomy, and stenting. Sixth, PTC or PTBD. PTC involves a tube being inserted under radiologic guidance into one of the biliary ducts. Mostly for therapeutic rather than diagnostic purposes. And lastly, HETA-scan, which is no longer used commonly, except in biliary atresia. For treatment, for asymptomatic cases, no surgery required unless patient has indications for surgery. Dietary modifications, expectant management and close follow-up. Counsel patient about symptoms of biliary colic, acute cholecystitis, and obstructive jaundice. Indications for surgery are increased risk of malignancy, chronic hemolytic disease, or individuals isolated from medical care for extended period of time, elderly patients with diabetes. Whereas for symptomatic cases, indications for surgery are abdominal pain, recurrent attacks, typical biliary colic symptoms, pain radiating to back. Definitive treatment will be elective laparoscopic cholecystectomy. Non-surgical treatment is rare, such as extracorporeal shockwave lithotripsy, or chemodissolution using ursodeoxycholic acid. For complicated cases, treat the complications. Cholecystectomy can be done to prevent future recurrence. For laparoscopic cholecystectomy, it is done using the Hassan open technique. Classically, 3-5 mm ports inserted under direct visualization at the sub-xiphoid, right subcostal area, and right flank. To minimize bile duct injury, establish critical view of safety. Calla triangle, plus-minus intraoperative cholangiogram. 5 criteria for a normal cholangiogram. Normal intrahepatic ducts. No filling defects. Smooth common bile duct. No stricture, narrowing of the common bile duct. Good and free flow of contrast into duodenum. GB dissected from GB bed and removed via umbilicus with the use of an applied medical bag. GB bed is irrigated and hemostasis checked. For recovery, 80% of patients discharged within 24 hours, most discharged by post-op day 2. For complications, specific to general anesthesia, stroke, heart attack, death, allergic reaction to anesthetic agents. Specific to procedure, injury to the bile duct, bile leak, injury to neighboring structures, unretrieved gallstone spillage, causing abscess and fistula, retained stones in the CBD, hernia at incision site, post-cholecystectomy syndrome, and related to any surgery, bleeding, wound infection, DVT, PE. That's all for this video. Thank you.